This is NDTV, and you're watching NDTV 24/7.
Hello and welcome to our show, Health and Wellness, Myths and Facts. Today we're going to talk about endocrine glands, which produce and secrete hormones that are responsible for many important body functions. Now they play a vital role on whether or not you develop diabetes, thyroid disease, growth disorders, sexual dysfunction and a host of other hormone-related disorders. Now, thyroid hormones play a key role in a number of body systems, but just how much do we actually know about the gland that holds such a huge responsibility for your health? Thyroid disorders are among the most common of all endocrine diseases in India. According to a projection from various studies on thyroid diseases, it's been estimated that about 42 million people in India suffer from thyroid diseases, and a third of thyroid patients in India are actually unaware of their condition. Thyroid dysfunction can, over time, result in obesity, joint pain, infertility, heart disease, so a range of possible problems there. And it can affect people of all ages. It's a silent disease whose symptoms are subtle and can often be overlooked during diagnosis. So timely diagnosis and complete treatment with appropriate medication can, of course, still yield successful outcomes. Well, to talk about all of that today, we have medical experts joining us on the show. Dr. V S Hari Kumar, consultant endocrinologist with the Magna Clinics and Fernandez Hospitals in Hyderabad. We have Dr. Arundhati Dasgupta, senior consultant endocrinologist and director of the Rudraksh Super Speciality Care in Siliguri, and Dr. Vageesh Ayyar, Professor of Endocrinology and former head of St. John's Medical College and Hospital, President of the Karnataka Endocrine Society as well. Thank you all very much indeed. We've got lots to talk about on a very important subject, but let me begin with Dr. Hari Kumar. Dr. Kumar, can all thyroid conditions be cured and cured permanently? Or would you make a distinction between some that can and some that cannot?
Thank you, Ankita, for that question. Actually, most of the patients, when they step in and when we utter the thyroid treatment, the first thing they ask is, do we have to take it lifelong? So, because that sets apart the patients that, oh, this has to be taken lifelong. So, I just want to explain to you that not many conditions where you require lifelong therapy. Some of the conditions which are like subclinical hypothyroidism or drug-induced conditions, or maybe iodine deficiency-induced hypothyroidism, all these will actually subside the moment you treat them with the respective therapies, and you don't have to use it for long term. Some of the conditions which are like over-functioning thyroid, that is hyperthyroidism or thyroid nodules, we treat them with a radioiodine therapy, and again that will also cure the patient permanently of the thyroid disease. Some patients who actually have a Hashimoto's disease, that is an underlying autoimmune disease, these are actually the patients who will require possibly a long-term therapies. And to say it more clearly, if you are treated adequately, and that will give you a cure permanently. So don't worry about taking it long-term. That's just a lack of some hormone which is being produced and which is being given from outside.
Right. Dr. Dasgupta, can there be fluctuations in thyroid hormonal levels from time to time? And, can there be symptoms some of the time and no symptoms at other times? How are we to recognize this when it's there?
Well, when there is mild disease, there at times might not be very prominent symptoms. But generally, if the levels are on the higher side, so the TSH is on the higher side, or it is very low, then the symptoms would be there. So signs and symptoms of thyroid disease would depend upon the level of the thyroid hormones. So you would have, if a TSH is high and the patient is, grossly hypothyroid, you would have symptoms of lethargy and weight gain and hair fall and, or infertility, menstrual menstrual disturbances, and so on and so forth. Conversely, if you have symptoms of hyperthyroidism when the TSH level is very low, then that would, patient would have weight loss or tremor or nervousness or, increased bowel movements and so on and so forth. So there can be fluctuation in the symptoms depending on the blood levels of the thyroid hormones.
Right. Let me also bring in Dr. Ayyar at this point on a related issue. What about, pregnant women? Do they need to screen for thyroid dysfunction more often and do this routine screening? And, if so, at what kind of frequency are we talking about?
I think screening pregnant women for a thyroid test is a very much essential. If it is not assessed properly during a pregnancy, either in the first trimester, based on the first trimester, we will find out what's the abnormality. Then subsequently, we need to decide the further testing. Untreated or untested thyroid disorder during pregnancy can result in a serious problem in the form of a abortion, miscarriage, including a stillborn. That's why thyroid testing is essential in all pregnant women. And thyroid testing is also essential in women who are taking medicine. We need to adjust the treatment. Somebody is tested positive, we need to treat accordingly. And it does affect the baby's IQ level. If it is properly not treated, they have noticed some decrement in the IQ levels of the baby, so that it is one of the most preventable mental retardation as of now.
Right. Thank you very much indeed for that, Dr. Ayyar. And let me also bring in Dr. Hari Kumar. Given that we're talking about pregnancy, what would you add to this? How does one manage hypothyroidism during pregnancy, Dr. V S Hari Kumar?
Yeah, it is one of the easiest disorders to manage is the hypothyroidism. Especially, it has a lot of importance in the pregnancy. Issues being that management is very simple. You just have to use a tablet of levothyroxine. Now, the tablet, there are multiple things which we explain to the patient whenever we are looking and prescribing the tablet. It depends on what the TSH is. The TSH is the thyroid stimulating hormone, which will tell the level of dysfunction the patient has. And it will also help in the gestational age. The week of the pregnancy also will determine the dose. The body weight of the patient will determine the dose, and possibly in some patients, the antibody status also will help in determining the dose of it. Some of the do's and don'ts we generally explain to the patient during management of thyroidism, especially in pregnancy, is the tablet we generally advise to be taken on the empty stomach. Lot of ladies would take iron or calcium supplement also, so we have to give some gap between that. The other thing is, the checking is a bit more frequent during pregnancy. Unlike the other states, pregnancy we correct that at 4-week, 6-week or 8-week intervals and then rapidly change as per the needs of the patient. And possibly some of it only advice is please take it with consultation with an endocrinologist. Don't do self-medication because dealing with two lives together during pregnancy.
Okay, no, don't self-medicate at all. Dr. Dasgupta, what about testing? Are there special tests like a thyroid ultrasound or biopsy in order to know that a patient is hypothyroid?
Well, no. I mean, to diagnose hypothyroidism, you will be just doing the biochemical tests. That is the T3, T4, and the TSH. These are blood tests. So if you have hypothyroidism, the TSH level is going to be high, and the T3 and T4 levels might be normal or they might be low. But the condition where we go ahead with an ultrasound is when maybe there is a goiter, there is a thyroid nodule, and we would want to understand what are the characteristics of that nodule or what are the characteristics of the thyroid gland per se. And once we have a look at the ultrasound, we would basically want to distinguish whether it's a case of a benign enlargement or is it a malignant enlargement. So there are certain characteristics that go in favor of malignancy. So if we do see any such characteristics, then we go ahead with what is known as the FNAC. We generally do not do a thyroid biopsy, we do an FNAC, and that helps us in the cellular diagnosis of the cause of the enlargement of the nodule or the enlargement of the thyroid gland per se. But just to diagnose hypothyroidism, a T3, T4, and a TSH is sufficient.
Right. Dr. Ayyar, if I can bring you in, how common is hypothyroidism when it comes to infants or children, and what are the symptoms that parents should be watching out for? Dr. Ayyar?
For all your surprise, hypothyroid can affect children and even a newborn. So only screening is the only way where we can detect early. It has been found that every 2,000 to 3,000 newborn have a thyroid problem. At birth, they need not have any symptoms. The testing is the only way we can detect the baby has a thyroid problem. If treatment is started early, we can prevent major problems of the growth and also mental development. See, what subtle things one can notice if baby has a hypothyroidism is there will be prolonged jaundice. There is a yellowness of the skin and the eyes will be prolonged beyond certain days. There will be a slowing of the activity. Baby may be constipated. Baby may be puffed up, especially around the face and the eyes. But these are the things as the days progresses. But at birth, baby may be absolutely normal without any features. That's why screening and testing for a thyroid in the newborn is very, very essential. It has been already in place in most of the countries in the West. I think even in India, many centers are doing it, but it should come in a big way at the national level so that we can prevent and detect and we can give a better quality of treatment for these hypothyroid kids.
Right. Dr. Hari Kumar, anything else that you would like to add to this, specifically about issues that concern children with hypothyroidism?
Yeah, some of it has been highlighted by Professor Ayyar. The important thing after birth, actually till about 3 years of age, your brain development continues to grow, and at this juncture, the thyroid hormone is essential for the brain development. So it is not at birth, it is right from childhood, you should be having an adequate thyroid function so that you prevent the preventable mental retardation in all these kids. And later on, it is the growth and development. Again, there is key important hormone which is responsible along with growth hormone is the thyroid hormone. So whenever a child who is not doing well scholastically in school, or possibly a child is not growing well, he is becoming more obese, but he is not growing in height, these are the times which the parent should be vigilant and get the child screened for a thyroid dysfunction, because this is the easiest one. If you diagnose early, treat early, you are preventing the mental retardation. Some of the girls may complain later on, it come with something like a early signs of puberty and with again obesity. So whenever a child is growing in weight but not growing in height, we should all look for thyroid disorders and screen and treat them adequately. That will give a long-term benefit to both the family and the parent, the child as well.
All right. We will take a very quick break on the show right now, but do stay with us. We're going to talk about what happens when elderly people are detected with thyroid hormone abnormalities and much, much more. We'll be back in just a moment. Welcome back to Health and Wellness Myths and Facts. We're talking about hormones, and we've already talked at length about thyroid abnormalities in children. But, what's the advice for an elderly person who's been detected with a thyroid hormone abnormality on routine screening? Dr. Dasgupta, if you'd like to take that.
Yeah, sure. So when we detect hypothyroidism in the elderly, generally we do not treat the milder forms of hypothyroidism. So, but if it is an overt, hypothyroidism, then we would be treating. But the treatment is slightly different in that we would start off at a lower dose and gradually up titrate, because we are concerned that, if you start off with a higher dose, there might be a risk to the heart. Also, when we start the patients on supplementation for high TSH levels, we tell them that be on the lookout for any kind of symptoms related to the heart. If you get palpitation, if you get chest pain, do let us know. Conversely, if you're talking about hyperthyroidism, we do treat even milder forms of hyperthyroidism in the elderly, which we might not, treat in the others. So it's slightly different when it comes to the elderly, and of course, the follow-up needs to be very regular. The checkups need to be done at regular intervals so that they do not land in any other kind of problems after starting the treatment.
Right. Dr. Vageesh Ayyar, if I may, go on a slightly different tack. How does one manage a thyroid nodule when it's detected on sonography?
These thyroid nodules are quite very common findings when we do ultrasound for other reasons. So patient undergoes a test for other nodules, and we notice the nodules. If it is quite big, it can impact on the neck, because neck is a very compact structure where there is a windpipe, food pipe, and there are vital vessels which enter heart and leave from the heart. So it can pressurize on these important vessels. We look into the patient's thyroid function. Based on the thyroid functions and also based on the certain important features what we see on the imaging on the thyroid nodule, we perform what is known as a fine needle test or a fine needle biopsy. It's a small needle test on the nodule, and based on the characteristic of the tissue we get, we decide further management. But most important thing to notice is majority of this, means more than 95% of these nodules are a benign, means they are not serious, non-cancerous.
Right. Let's go back to talking about hyperthyroidism and pregnancy. Dr. Hari Kumar, what are the relations, if at all, and, what are the ways of management and the warning signals, as it were?
Yeah, usually hyperthyroidism, especially in the pregnancy, has a lot of issues and a lot of complications. Commonly, what we encounter is not the hyperthyroidism, but most of the times, early pregnancy, the ladies would be having features of nausea, vomiting, what we medically call it as a hyperemesis. So they would be keeping early morning sickness, we generally call. Some hormones change in that perspective whenever you conceive, and they also stimulate the thyroid, and they have some symptoms which are similar to a thyroid overfunctioning. So you have a system which is like mimicking both these conditions. So in those patients, we actually look at screening them, looking at what exactly is the underlying disease. We may have to do some blood tests and identify the underlying cause, because if it is a thyroid overfunctioning, which is a commonly known as Graves' disease, the treatment is different. But if it is just a pregnancy related issue, what is known as gestational toxicosis, we just have to observe the patient, maybe give them more supplement fluids or then antiemetics to control the vomitings. Right. The thyroid also will settle on its own. So it's important to differentiate between these two conditions, especially in the management of hyperthyroidism in pregnancy, because the treatments differ between the two.
Dr. Dasgupta, anything that you would like to add to that about the management of hyperthyroidism during pregnancy?
So once we've ruled out gestational thyrotoxicosis and we are sure that this is, hyperthyroidism because of a problem in the patient herself, then we have to treat. But it's a difficult situation, because on one hand, we would not like the patient to remain in the hyperthyroid condition because that has its repercussions. On the other hand, we are concerned about the effects of the drugs that we are going to put the patient on, because they would cross the placenta and reach the fetus. So generally, we start off with lower doses than we would have started off, in the non-pregnant state, and we try to keep the levels of the T3 and T4 at the high normal. Generally, when we are treating hyperthyroidism in other situations, our main aim is also to get the TSH to normalcy. Here, we are happy keeping the T3, T4 at the high normal level, even if the TSH levels are low. So there are two groups of drugs that we generally use. One group of drug is generally used in the first 3 months because the teratogenic effects are slightly lesser than the other one, and then we shift to the other group after the 4th month onwards. And of course, the testings, as we were told earlier, have to be done very regularly at monthly intervals so that we can adjust the dose accordingly.
Right. One last question, Dr. Ayyar, what kind of effect can hyperthyroidism in a pregnant mother have on the fetus?
Thyroid hormone is very essential for the brain development of the baby. If mother is deficient and baby doesn't receive good hormone support when it's in the womb, it may not grow properly, especially the mental acuity or IQ, and also the physical growth. So it may result in the premature birth, sometimes even the miscarriages or even a stillbirth. And the most important, we have to treat a mother if she is a hypothyroid to prevent mental retardation in the baby. So that's the most important thing.
All right. Right, that was a very comprehensive half hour in which all aspects of hypo and hyperthyroidism were, I think, covered, particularly for those who are sort of new to the subject. So thank you all for joining us on the show. We hope this has been useful. Thanks for watching.